The problem is you do see a lot of antisocial people succeed. Loneliness is as big a risk factor for ill health than death.
We live inside our heads.
You go cold turkey, you go into withdrawal.
There is a lot of value in the stuff that we struggle with.
Better Thinking. Conversations with experts exploring all things psychology. Welcome back to Better Thinking. My name's Nesh Nikolic, and today I have the privilege of speaking with Dr. Donel Martin, a practicing clinical neuropsychologist and academic researcher at the Black Dog Institute. Donel's work centres on investigating novel treatments for psychiatric disorders with a particular focus on brain stimulation techniques such as transcranial direct current stimulation and psychedelic-assisted therapies to improve cognitive functioning. Donel has been awarded 2 internationally competitive early career researcher grants to advance his research in therapeutic brain stimulation. He is a senior member of the coordinating team for the Clinical Alliance and Research on ECT and Related Treatments Network, an extensive national and international collaboration of hospitals that collect standardised clinical care data to enhance treatment practices. Since 2014, he has also been a lecturer and demonstrator on the Black Dog Institute's TMS and tDCS training courses and a guest lecturer on non-invasive brain stimulation in postgraduate university programs. I really enjoyed speaking with Dr. Donel Martin. He is really well versed in this topic, and I'm excited to share this conversation with you. So let's jump right in. Donel, a big thank you for coming onto the program today. I'm excited to talk to you for a couple of reasons. One is looking at how we can improve cognitive functioning, but secondly, trying to find out a little bit more about the 2 approaches that you've done some research into, because both of those I've got very little experience in and knowledge of. So, firstly, thank you for coming onto the program.
My pleasure. Thanks for the invitation.
I might start with asking you, how did you get into researching this, into this space? How did this come about for you?
So what happened was I did a PhD in psychology in Adelaide. And then I came to Sydney to do a master's in clinical neuropsychology. So I'm also a clinician and work in private practice. And so I needed a job when I came to Sydney, and I was very fortunate to join a very small emerging team based at the Black Dog Institute that was investigating kind of like this new frontier of brain stimulation for treating mainly depression, but could also be applied to other neuropsychiatric conditions. So we started off as a very small team, so I was the 3rd person to join the team. And today we're a team of 25 plus people that are like pretty much the leading team in interventional neuropsychiatry, like in Australia. So it's been a bit of a journey. Yeah.
Yeah. Wow. Now, most of us are familiar with brain stimulation relating to TMS. It's something that many of us have read about, heard about, discussed. But this is something a little bit different. This is transcranial direct current stimulation. How is that different?
Transcranial electrical stimulation is kind of like the broader umbrella term, which transcranial direct current stimulation is kind of like the main type that's being investigated. So it's been around. So electrical stimulation for the brain has been around for pretty much like people have been investigating it or looking into it for kind of like hundreds of years. And then it wasn't until the 1960s, so with the development of kind of like clinical trial methodology, so where we have kind of like placebo or sham control and randomization. It was only until the 1960s and early 70s that the first kind of like controlled, proper, more rigorous clinical studies were conducted. And they were conducted in what they called at the time mental asylums. So for really severe people illness, and so there was limited medications available for people with these severe illnesses. And so there was a few groups that investigated kind of like this old technique which they called brain polarization, which is essentially, using 2 or 3 electrodes placed in the head or one off the body to stimulate the brain, and they used very small currents, and people would pretty much just walk around, in the asylum all day, and then I have the stimulation on at a very low intensity for like a week or so, and then there was like a placebo control, and then see if it had effects on kind of like their depression, their thinking, and other kind of symptoms as well. So those were the first studies that were conducted in the 60s, and then it was pretty much abandoned after that, with the advent of interest in pharmacological treatments, so new antidepressants. I know you've had people on your show talk about SSRIs and things like that. And then so that gained a lot of attention, and people kind of like forgot about transcranial electrical stimulation. And then it was kind of like rediscovered or revived in around 2000 or so, by some doing some new kind of with the advancements in technology and neuroscience about depression. People started to do some basic physiological studies, which interestingly showed that when you apply this transcranial electrical stimulation or transcranial direct current stimulation, that you could actually increase the brain's excitability after the stimulation ended, and that these effects could last for, like an hour and a half or so. Um, and subsequent studies show that this was actually due to, it changing kind of like the neuroplasticity of the brain. And people were interested, okay, maybe this would be useful for depression. And then people started investigating transcranial direct current stimulation using these, modern technology, modern approaches for depression. And then there's some initial studies that showed that it had significant antidepressant effects. And then also some preliminary studies around the early 2000s that it had effects on cognition, so it could improve people's thinking. And then that was the time that I joined the team, when these initial studies were coming out. And that really piqued my interest as a, neuropsychologist in training, that, we can potentially develop this technique to help to improve people's cognition.
Hmm. The brain excitability that you mentioned, that would continue on after treatment, or intervention, you said it was up to about 1.5 hours or thereabouts. And was that thought to be connected with neuroplasticity? Was that somehow demonstrated as well that it had that effect, or that was the theory that kind of came about thereafter?
Yep, so it was demonstrated. So they did kind of like pharmacological challenge studies where they kind of like you block certain neurotransmitters or certain like calcium channels and things like that, and then that actually stopped. You didn't get those effects. So that was able to be demonstrated. It's very similar to what happens with TMS. TMS similarly causes increases in neuronal excitability, and we actually, to show that tDCS caused increases in brain excitability, you use actually TMS to kind of like stimulate the motor part of the brain. And when you use TMS to stimulate the motor part of the brain, you get twitches in your finger. So it actually causes neuronal depolarization. And so how we showed that it caused increased excitability was you apply the tDCS first, and then you apply single pulses of the TMS to that same brain region, and you see larger muscle movements. So it kind of like, so it means that the motor cortex is more excitable when it got the TMS stimulation, and then that caused larger muscle contractions. So, and then, if you give people certain drugs that, modify or block certain neurotransmitters that are related to neuroplasticity, then you minimize and you don't get those kind of like after effects. So that's basically how it was demonstrated.
Mm-hmm. Mm-hmm. And what has been the progression to looking at depression, for example, as a presentation, or I assume others as well?
So depression has always been the first kind of like disorder that people have looked at in terms of applying brain stimulation. So you'd be familiar with electroconvulsive therapy, ECT, which is actually the most effective treatment in psychiatry. And that was invented in 1938, which showed that if you apply this kind of like strong controlled electrical stimulus that generates a seizure, that had profound antidepressant effects, decreased people's psychosis, like really significantly improved people and reduces suicidality. So ECT, once it was discovered that you could do this very easily with electricity, that spread across the world. But then what happened was, there's a lot of concerns about ECT, and there's kind of like controversy and stigma associated. So usually it's only really applied for people that are really severely ill, where they're in hospital. And so it's kind of like what can we do to help this really severely ill person? We give them ECT. But there's a lot of people that aren't that severely ill. They may not have psychotic symptoms, but are still constantly depressed, and they've tried multiple antidepressant medications and haven't gained clinical benefit. So they're still unwell. They still potentially could be suicidal. The antidepressants don't work. What else can we do? So that's why the kind of like the research direction went to looking at, okay, let's investigate electrical stimulation, like transcranial direct current stimulation, and TMS, which are both forms of electrical stimulation of the brain. Just one uses strong magnetic fields, the TMS, which induces currents in the brain, but the tDCS, that just applies a weak electrical current that passes from one electrode through to another. And with the development of our understanding of the neuroscience of depression, we were able what was determined was there's a particular frontal part of the brain, the dorsal lateral prefrontal cortex, so it's about here on the left side, that if you stimulate that particular part of the brain, which is interconnected with networks that are dysfunctional in depression, and brain regions that we know are also dysfunctional in depression, deeper brain regions, that you get antidepressant effects. And so when we apply tDCS for depression, we similarly to TMS, we stimulate the left dorsolateral prefrontal cortex and try to increase excitability in that brain region. And there's been tons of research from randomized controlled trials that has significant antidepressant effects. And so that's kind of like the story of how electrical stimulation kind of like became treatment for as treatment for depression, because like depression is very common. It's one of the most common psychiatric conditions. And there's lots of about a third of people have like this treatment resistant depression that don't respond to psychological or pharmacological treatments. And so it's this big sample of people, this big population that where different forms of brain stimulation can potentially be applied.
And just very gently, I suppose, switching topics or introducing a new topic, the psychedelic assisted therapies. Is there some relationship there in terms of the excitability of the brain that you've researched, or these are just completely two separate concepts and ideas about how they work? I know from neuroplasticity sort of point of view, but it's such a big broad term, and sometimes it's a bit challenging to know what that exactly means. But how would you relate those two, or is there even a relationship at all?
There's not very much of a relationship. They're very, very different approaches. So like the psychedelic, so the traditional psychedelics like psilocybin, DMT, LSD, they work mainly on upregulating serotonergic receptors, so the 5-HT2A receptor. And that's kind of like what's associated with the psychedelic experience. And then when that's applied to treatment of depression or other severe psychiatric or difficult to treat psychiatric conditions, it's really that producing that psychedelic effect, which is really critical for getting antidepressant effects. And then it's not just the drugs just by itself, it's you need to add the psychedelic assisted therapy. So you add the psychological therapy, which is talking through, kind of like preparing people for the experience, uh, talking to them about their experiences when they were tripping, and then helping to reconcile those thoughts and helping them to change the behaviors. So they're completely different approaches. One's just applying electrical stimulation in some form or another to kind of cause neuroplastic changes, while the other is really a integrative therapy that's based on a combined combined psychedelic experience and the integrated therapy. So yeah, two very different approaches.
And is there any preparation and integration with the TMS side? What do we assume is occurring with the TMS interventions if there isn't a prep and integration in terms of discussing, reconciling one's challenges, difficulties pre and post? How do we how is that looked at?
So yeah, it's very different. So when you receive kind of transcranial direct current stimulation or transcranial magnetic stimulation, you don't really feel that much at all. And you actually need to have like daily repeated treatments for multiple weeks, in order for the antidepressant effects to occur. So it's not a dramatic antidepressant effect like you get with traditional psychedelics. So, with traditional psychedelics, you can get a really significant antidepressant effect, in even like a week. With the transcranial electrical stimulation, it's much slower. So it's a gradual effects. And that's what we think it's to do with changes in neuroplasticity and, people's mood slowly changing and then the behaviors slowly changing. So it's where the psychotherapy is important with the psychedelic assisted therapy is just I guess, coming to terms with and integrating your profound mystical experience from the psychedelics and helping that to gain insights into changing your behaviors. So they're two very different approaches.
Yeah. So with ECT, it's something you come in for, the treatment occurs and you leave. There isn't a behavior change component that is specifically discussed, targeted, worked on. It's almost like taking a pill. This is, you take a treatment, you leave the clinic, you come back the following day, you do it over a series of weeks. Obviously, it would be different for each person, but generally speaking, and there isn't a focus on any particular outcome other than trying to create some stimulation with the concept of some neuroplastic sort of effect that may be positive in nature.
Yeah, so that's often the people with the treatment-resistant depression that they're the most suitable for the transcranial, different types of transcranial electrical stimulations. I'm talking about like ECT, tDCS, TMS. They've often been sick for many years. They've had many episodes of depression. They've seen psychotherapists. They've had clinical psychology sessions. Like they often have, despite all this, they're still unwell. And often people, we've also seen as, kind of like hesitant to re-engage with the kind of like psychological therapy, when you've had such a bad experience, you haven't gotten any better. And that's where when we apply these forms of electrical stimulation to the brain, it's usually just kind of like a pill. And some people prefer that as well, because psychological treatment is not for everybody, as you would know. And it's also, can be confronting, can be, a bit like, can be, it takes up time. You have to go see a therapist and so forth, and you may have therapy ongoing for months, if not years. Yeah, the electrical stimulation approaches are not just like a pill just by itself. Um, but however, it's important to once people get better, or if they show some improvement in their mood or their thinking, um, often with these electrical types of stimulations, just like pills, people keep on taking pills after even after they've gotten a bit better, and they have difficulty coming off them. So often what we see with electrical stimulation, different types of electrical stimulation as well, is that we need kind of like continuation treatment where people need to continue having treatment in order to kind of like maintain their mood response. And that's also, that is also looking like what's going to happen with the psychedelic assisted therapy as well. That it's not just you have one profound trip experience, but it looks like people are going to need more treatments after that. So it's just the nature of the chronic illness of of depression, particularly treatment resistant depression. And it probably similarly applies to other, severe psychiatric conditions like people with psychosis, obsessive compulsive disorder, and so forth as well, that um, it's not just you have your acute treatment period, whatever that is, whatever type of treatment, but you need to continue having some treatment in some form in order to maintain the response. And one approach that's been looked at is to, once people feel a bit better, they have more motivation, they may be more energetic from the brain stimulation treatment or whether it's a psychedelic assisted therapy, is that they're more likely to be able to engage in or re-engage with psychological treatment. And that is probably preferable, is once you get them in that good space, is to then apply the psychology and then help that to maintain response. So that's where I see kind of like the place of clinical psychologists like yourself as having a role as pretty much, we give them the boost with the electrical stimulation or, other interventional treatments, but then kind of helping people to, change the behaviors, change their thinking. Once their brain is like, more plastic or, they have, they're more cognitively alert or with it, or their memory might be a bit better. That's probably a better time to, apply the psychological treatment to help keep people better in the longer term.
Mm-hmm. It sounds like there's something deeply profound occurring for the treatment resistant, depression, so to speak. I've often had guests on or discussed with my colleagues, also, hold personally myself the belief that, this experience of depression is quite a normal response to a particular set of conditions, whether it's life conditions, because life can be very, very challenging and difficult. There's plenty of demands and there's plenty of responsibilities that we hold. Lots of, interpersonal relationship, challenges and difficulties. Many of us can feel lonely or have a loss of direction, purpose, meaning in our lives and so on. And so it seems like this type of approach can be really useful to begin a process of re-engaging in reviewing one's life, whether it's through the neuroplasticity effect or re-engaging in therapy, or for someone might be just re-engaging in a different social network and starting a new path. But there has to be some type of conditional change as well, and this is a part of a support system to see what else can change in one's life. Is that right, or are we assuming there's something structurally deficient in one's brain that needs to be changed somehow? Well, what's the thinking?
So, depression has kind of like a genetic component as well. And, there's many different presentations of depression due to a whole range of those factors, like you've just mentioned. Some maybe like related to particular circumstances that people have. Or it could be a more kind of like biological based depression, like where people have a family history of severe, more what we call kind of like a organic depression. Like you may have heard of melancholia, where people have a particular presentation of symptoms that are more that are more similar across different people than depression, which is also a large umbrella heterogeneous term that refers to a whole constellation of different symptoms as per, the DSM-5.
Sure.
And it's where we think the kind of like the brain stimulation part more fits in is for people with the more kind of like biological based depression.
Okay.
And to help them just to, similarly to, I guess, the same kind of approach or thinking behind giving people medications. And, you're trying to fix something that's biologically dysfunctional and or trying to, you're trying to fix something that's biologically dysfunctional. And then that's where, and then once you've kind of got that processes in place, that's where I think behavioral interventions, would be more useful. But for people in general who, experience depression, so, a lot of people may just experience depression kind of like once in their lives. But, we're talking about, and for those people, then, psychological therapy is the gold standard, as we know. In combination with pharmacotherapy. But psychological treatment, if you go to your doctor and you talk about symptoms of depression, you're going to get a referral to see a psychologist because that's the that it's better to talk to someone and learn some skills, strategies to help overcome your symptoms. But when it becomes more chronic and more ingrained, like what we get with the treatment-resistant depression, and then I think that's when something more drastic or more biological-based intervention is required, and that's where these kind of interventional psychiatric treatments fit in for those people.
Can we double click on the organic, I suppose, presentation? It's a complex one, right? We're trying to understand what is it a trait-based perspective that someone is born with. I know that we sometimes say that there's links to other people in their family experiencing a similar thing. These are real difficult concepts to properly understand. There's a ton of assumptions that go with it, but what's meant by an organic basis to someone's psychology or in this case depression?
So I'm not a psychiatrist, but I'm aware of kind of like this term of melancholia. It's not a official kind of like diagnostic term like as the DSM-5, but from a kind of like psychiatrist perspective, this is what a presentation that they commonly see in the more kind of like people with severe depression. So it's where people show what they call psychomotor retardation. So they're kind of like real slow in their movements. They have real problems with their sleep. So this is what I mean by organic, like, and yeah, often they have a similar kind of look or absence of look in their eyes or like their face, or lack of reactivity. That's what I'm talking about in terms of more organic kind of based. Whereas, other people that may present with depression may not seem like they're depressed at all, you know, maybe totally reactive, laugh, smile, um, but nevertheless, they still feel really sad and miserable, like, and don't enjoy things. So, yeah, so that's what I mean by more organic, is when it really starts to kind of like show physically, and where you have those kind of like physical symptoms, like, the poor sleep, don't want to eat, things like that.
Yeah. It's really on the more chronic, usually I suppose more chronic presentation, where we can see the actual physical limitations, psychomotor retardation, occurring. It's not usually the first part of depression that someone would see. It's when someone's deeply depressed.
Yeah.
See them, it's almost like a helpless state. They've resigned to their life being the way that it is, and then nothing's going to change it. There's a helplessness, there's a hopelessness that kind of comes about it as well. And so you see almost very little expression, if any, in the face as an example. Sometimes it can be an incredible amount of sleep, or it can be very disturbed, disrupted, fractured sleep as well. So there's tiredness or lethargy that is profound, very pronounced.
And real cognitive issues as well. So, and that's kind of like my area as well. So what we know is like about kind of like 30% of people with major depression, they actually experience significant cognitive impairment. And so, that may also be part of the biological kind of organic component that what I'm talking about here. And there's no, for most people that do have those real cognitive issues, so they might have difficulty engaging in psychological therapy. So you might, talk to them about strategies, or, behavioral activation techniques, or, do other forms of cognitive behavioral therapy. And then the next week, they won't remember anything that you've talked to them about, because of these kind of like cognitive issues, difficulty with, paying attention, memory. So that may also be more at the severe end of the spectrum of like more organically based. And we know that those cognitive issues are, are associated with changes that happen in the brain, particularly the memory related centers. So where you get kind of like atrophy of the hippocampus, and that is related to, these cognitive deficits that people see, for that small portion of people that do have those real severe difficulties.
And is that exactly what this, the TMS slash tDCS is targeting, where if there is a great, let's call it retardation in cognition, or the psychomotor side, that applying over a longer period of time some type of stimulation to that part of the brain creates that excitability, which therefore produces the effect of neuroplasticity. So the hope is that someone who has a sort of more entrenched organic presentation, it gives them a chance to re-engage differently, to see the world differently, to be stimulated in some sense, activated in some sense. Then that hopefully something lands, something shifts, there's a perspective change. It's not specific what needs to occur, but at that point, because we're kind of at the very pointy end of the stick, it's really important to give everyone a chance. And that's that hope of let's do something. We're not fully know what it will do, but we do know it excites on a general basis. And then we hope that something will come from that. And there's some data that obviously says that there's certain percentage you get value out of that.
So when we're talking about the kind of like the spectrum of brain stimulation techniques, so I talked about electroconvulsive therapy before, which basically is such a strong form of brain stimulation. You're stimulating the whole brain. And now there's, there's large consortiums that looking at neuroimaging data from before and then after people have a course of ECT for depression. And then some results that have come out in the last, 5 to 10 years we're talking about hundreds of people that have had MRI scans before and after a course of ECT. And then these studies shows that it actually causes profound neuroplastic changes where you get increases in brain volume from the ECT. And where those increases are greatest are actually in those memory centers. So in the hippocampus, particularly one region called the dentate gyrus, is where you get this synaptogenesis and you get large, substantial increases in brain volume there. But you also see increases in gray matter volume across the whole brain. So that's what happens with ECT. And then what happens also with ECT is it's very fast acting. So people with those really severe organic based depression or that kind of those kind of characteristics, that often within a week or so, they look completely different. So we talked about, the symptoms before of the kind of presentation that people have, the lack of reactivity, slow movements, staying in bed or disrupted sleep, that often, after a week or so of ECT, that they look completely different. They may be, and that's very noticeable by everybody. Even though the person may not feel that different, everyone thinks that they look a lot better. And it may take them psychologically a bit of time to actually, start to change in terms of their thoughts and about their feelings in order to gain that kind of like a mood improvement. And then with the more weaker forms of brain stimulation, like those other ones I've been talking about, the transcranial electrical stimulation and transcranial magnetic stimulation, they don't cause, so the TMS, the research has shown us when you do the MRI scans before and after that also shows, it also causes changes in gray matter volume, but it's not the hippocampus because you're stimulating a very focal brain region on the cortex. And the effects of TMS are really kind of like network related. So, you're really looking at downstream effects from the repeated treatments, and then that causes, changes in neuroplasticity and causes very, very small changes in terms of increases in brain volume compared to ECT. And then transcranial electrical stimulation like tDCS is even weaker than TMS. And to the best of my knowledge, no one's actually shown that actually causes changes in brain volume. But presumably, if you think about along that kind of like spectrum of brain stimulation, that there may be things going on, but maybe they're just so small that we cannot observe, with traditional MRI imaging techniques. Maybe you need more high resolution or more advanced techniques, or use machine learning or things like that in order to be able to understand the kind of brain actual changes that occur with the repeated treatments with the tDCS.
And do you know why one approach might be used over another, and how that decision's made in terms of whether it's tDCS, whether it's TMS or ECT? How is that sort of approached? Do you have any insight into that? And maybe you can also mention something about, you mentioned that it's one of the ECT in particular that targets the entire brain, is one of the most powerful psychiatric sort of interventions.
Yes.
That was interesting. I want to double click back on that so I don't forget. But how those three approaches, and I'm sure there's other variations, but how they decided upon, why would one go down one route versus another as a starting step?
So there's different considerations. A lot of it is access, and kind of like affordability. So ECT has been available in Australia for decades, but it requires, and it's Medicare subsidized. So, if you're severe enough to go into, a public or private hospital that has ECT, then and that might be the best thing for you because it has the most rapid therapeutic effects. So if you use ECT for people that are really, really severe, that you want to get people well quickly, like it might be, acutely suicidal. They, may not be eating, um, or, catatonic even, where the psychomotor retardation has gone so bad that they don't even talk. Um, so that's kind of like where the ECT space is. And then, but you need to be hospitalized generally, to get ECT, even though there's new so-called weaker forms of ECT where you can receive that as an outpatient. So you can go in, get your treatment, and then leave that same day. But it's really about accessibility of where that kind of treatments are available and how much it costs. Because like ECT requires general anesthesia, requires a whole team. It's a very intensive and highly medicalized procedure. So it's expensive. So you really need that kind of like government subsidy to be able to access that, and also you need to have the appropriate services available that have an ECT suite with all those medical expertise to be able to do the treatment appropriately. TMS has been available in Australia for 15 years or so, but for majority of that time, it's been only available pretty much in private settings where people have to pay $200 a treatment. And so that's or more. And so if you're having daily treatment for 4 to 6 weeks, that all adds up. And so it's like where those clinics are available, where those clinics are, how much they charge. It's really about equity and accessibility for people that getting TMS. But only a couple of years ago, TMS received a Medicare subsidy, so now it's a lot more accessible for people. And then with transcranial direct current stimulation, that is pretty much only available at the moment in private clinics. There's no Medicare subsidy, but it's really, but in a way, it's actually has the most potential for accessibility because the new devices for tDCS are like these handheld devices, and you get this headset to apply the stimulation, and you can do it at home remotely under medical supervision. So ECT, you need to go to hospital. TMS, you need to go to the clinic every day, get your treatment. tDCS is something that you can get trained and learn how to do it, and then you can go home and do self-administration with your doctor remotely monitoring you, via internet. You can do telehealth, and you can record your symptoms, and it goes onto like a platform, and the doctor can monitor your symptoms and side effects and things like that. But that's the new kind of forefront. Although it's not Medicare subsidized, people were trying to get it Medicare subsidized, been unsuccessful so far. But that could be. It's really, about accessibility. But I think like recently though, a tDCS device was approved by the FDA in the United States, based on a really large positive clinical study of home-based tDCS. So that's going to really take off now. Now that you get that stamp of approval by the FDA, tDCS, they're going to try and sell millions of these devices, like in the United States. So that will become a lot more accessible. There'll be clinics available where you can do this remote. So it's a lot less burdensome for people. And so, yeah, so really those are the main kind of like factors involved. It's kind of like where you can get the treatment, what's the treatment involved, and, costs involved or whether there's subsidies involved.
And what are the how efficacious is tDCS? Is it comparable with other interventions? How does it rate?
So there's been a couple of large studies in Brazil where they've compared tDCS to like standard SSRIs. And the most recent of those studies found that actual tDCS, although it had significant antidepressant effects, it wasn't as effective as the standard SSRI. So it's a much weaker, it's like also of the different types of brain stimulation that I've talked about, how it's given in the clinical trials, it's been shown to have, it's the weakest of the antidepressant effects of those different types of brain stimulation that I've been talking about. But having said that, though, the clinical trials are restricted to giving tDCS people typically give it in the same kind of way. So that's notwithstanding the fact that there could be alternative approaches to giving tDCS where you could potentially get more larger antidepressant effects that just haven't been studied yet. So I talked before, right at the beginning, about the original controlled clinical studies in the mental asylums of this transcranial electrical stimulation. They gave it like people walking around having it all day for like 5 days in a row, and then they showed really really good, really promising antidepressant effects and people's thinking and clarity of thinking after only like a week. But when tDCS has been investigated in the modern clinical trials, it's generally people just get it for 20 minutes or 30 minutes a day. And so, one promising research direction, which I think will be available, with these new kind of at-home devices, is they will be able to do similar kind of treatments to what was done in the early days, which has not been examined yet. So, with the home self-administered stimulation, you could give multiple treatments a day. You could give much longer, because you can walk around with this headset on. Like, you could walk around your home for a week wearing the headset. You just need to keep on applying, like check the skin, make sure that that's still, just monitor side effects appropriately and so forth. But you could, have it as a wearable kind of thing, like that it's, you could have much larger stimulation rather than have this really restricted, go into a clinic, get 20 minutes of stimulation and go home. That, it opens up a whole new frontier, I think, of being able to actually apply it where you actually enable this kind of like home-based stimulation. So, we'll see where it goes, where the research goes. It's something that we're actually investigating at the moment. I'm leading a clinical trial of tDCS in people with anorexia at a private hospital. And then part of that clinical trial is there's an open label period where after they do the randomized control period, which is 8 weeks, so that's actually they get either TMS or tDCS, and then there's a placebo of both of them. So there's 4 groups over 8 weeks. And then after that 8 weeks, they have the option of having this at home tDCS for 3 months. And we're really interested to see how these people go, how feasible it is for people to do those treatments at home daily for 3 months, how acceptable it is, do they skip heaps of sessions or not? And then what are the clinical outcomes? Does it actually, we're not only interested in kind of like the core symptoms of anorexia, but what are the effects of having this kind of like prolonged treatment, at home on terms of people's mood, what's the effects on their social functioning, their day-to-day functioning, and the area that I'm particularly interested in, what are the cognitive effects of that? So Yeah, with these new advances in technology, like that's where kind of brain stimulation is that's the direction where it's going.
The accessibility, as you mentioned, just really skyrockets once it becomes a wearable, so to speak.
Yeah.
What have the longitudinal, what have there been longitudinal studies, and what have been the length of periods that have been reviewed, and what are they based against in terms of, no treatment at all, treatment as usual? I know it's complex because someone who is at the more severe side of mental health, it's difficult to get longitudinal where all the controls are in place to compare it against.
That's right. So, and it's also extremely expensive to do these kinds of studies, as you imagine. So we're talking to do a longitudinal study like that, we're talking tens of millions of dollars. Like, what's really interesting though was there was a longitudinal study that was just published last year, which looking at the cognitive enhancing effects of tDCS. So what they did was it was a sample of nearly 400 people. It was a big study conducted in Canada. I think it cost $300 million to do this study. And it was kind of like, and what they looked at is this combination of applying tDCS plus doing cognitive remediation. So that's doing kind of like brain training exercises aimed to improve specific cognitive functioning. And there was initial kind of randomized control phase that went for 8 weeks, and people did that, 5 days a week for 8 weeks, 1 hour of training with the brain stimulation. And then they followed them up for 4 years, and they did a couple of booster sessions of the stimulation each year for like those 4 years. And interestingly, so this is not at home tDCS. This is in clinic based tDCS where people had to come in and get it. So this is before the development of these handheld wearable devices. And interesting, what they showed is like longitudinally, and these were when people who are at increased risk for depression, no, at increased risk of dementia. So people with mild cognitive impairment, and also people with depression, and and these are older people as well, so aged over 60. The people that received the active tDCS and with the cognitive training at the same time, that they showed less cognitive decline over those 4 years compared to those that received the double sham. So that was like both sham tDCS, so placebo tDCS, and also placebo cognitive remediation, placebo cognitive training. So where people weren't challenged, they weren't learning, developing new skills. It was pretty much set at a low kind of like base level of doing exercises. So that shows that, that's quite actually promising that, that this, but the issue with that study is that the longitudinal study was comparing a double active condition to a double placebo condition. So you don't know exactly what's actually causing these kind of like longer term changes. Is it the tDCS? Is it the cognitive remediation, or is it the combination of the two? So you don't know which of those is causing those longer term effects. So that's kind of like one longitudinal study, but that gives you the idea of how expensive it is to do these kind of controlled studies longitudinally. But we've been doing tDCS at the Black Dog Institute since I think 2007, where our team did the first tDCS study in depression in Australia, our first controlled trial. And some people with the more treatment-resistant depression, that this was the treatment that worked best for them. And they kept on coming back. They wanted more and more tDCS. And so we've actually written case reports of, I think one person in particular who received tDCS ongoing for, 3 or more years. I think they're still receiving it now. And so they've had it, for probably like 8 years or so, they've been getting tDCS. And there isn't any negative effects in terms of effects on their thinking. So we monitor them closely. That's actually my role, is to check and monitor the cognitive safety of the treatment. But it's the best treatment that works for them. But they need to keep on having it. So it seems that it's safe. in a longer term, so we demonstrated safety. But yeah, it's as I said before, often with these antidepressant treatments, no matter what type of treatment it is, you need to have continuation treatment to maintain it. Um, but to do a long-term controlled trial, it's
That's very
prohibitively
difficult.
expensive. Yeah.
Have there been any, switching gears slightly, any longitudinal studies for the psychedelic assisted therapies for the treatment resistant depression side?
So people have done like long-term follow-ups after one or two kind of like I guess acute treatments, which is the people who have the psychedelic. So they have the initial psychotherapy to get them used to it. Then they have the psychedelic experience with psilocybin. And then they have the integration therapy, so usually a couple of sessions afterwards. And then they may repeat that again if they're, looking like they're becoming unwell again, or if they become unwell again, and then monitor them for 6 months or more. But yeah, that tends to show the same pattern as what we see with other types of treatments for people with treatment-resistant depression, that no matter what type of treatment it is that you give them, a lot of people relapse because of the recurrent nature of the illness. And so they need to have either another acute course, another new treatment, like have another acute course of whether it's brain stimulation, or have another psychedelic assisted therapy. But it's not the ultimate fantastic therapy that it's been made out to be in the media, where people were suddenly cured forever from psychedelic assisted therapy. It's not like that at all. That people will relapse, but most people would.
Yeah. I'm only speaking from my clinical experience. Is that when someone's in that state, and to be fair, I don't have a huge number, because the clients that I see in private practice don't tend to continually engage with talk therapy, probably for numerous reasons. One might be because they don't feel that it's giving them the benefits, the value. Another one is it's very difficult for them to engage in anything, because it's so severe what they're experiencing. But if you were experiencing this sort of treatment-resistant depression, how would you go about the supports that you would seek? And we're not saying that this comes from, the best, that the research says X, but just on a personal level, you've obviously done research, you work, in a clinic as well. How would you approach treatment from a personal opinion? And this isn't advice, so I'm just going to caveat that again. It's not advice, but how would you approach it? I'm curious to hear your viewpoints.
So if I had treatment-resistant depression, so that I guess one of the things that I would try first would be the transcranial magnetic stimulation, and see that. And it's important to, when we talk about transcranial magnetic stimulation, of what actually the treatment is involved. So you have to go into the clinic, you have to see your doctor, you need to get the treatment daily for a period of 4 to 6 weeks in order to get antidepressant effects. So what's actually happening is that you're getting behavioral activation, so which is really important as a psychological treatment for people with depression. So if I was having where you're kind of like forced to get out of bed, go to the clinic, talk to the nice people at the clinic, have your treatment, then go home, and it becomes a daily structured routine. And so that would be, I think that is, and we know from the placebo-controlled studies of TMS that the people that get the placebo TMS, they also tend to show large antidepressant effects. And it's mainly because of these non-specific factors or because of the behavioral activation of actually having to get up, go to the clinic, talk to the nice people, go home, repeat day after day for weeks. So it, although it's not, it's a brain stimulation treatment that doesn't have a specific psychological therapy component, it does involve, I guess, a psychological intervention in a
Mm.
way of getting people to do that. So just forcing yourself to do that, I think that like the placebo-controlled studies of TMS show that adding the TMS gives you more benefit than the sham TMS, despite both people getting active TMS and placebo TMS
Mm.
going and doing the same thing every day. So you still get that extra benefit from
Yeah.
the DMS, but like that's the kind of treatment involved because it actually does involve the behavioral activation kind of component. And that
Yeah.
may, once you're out and about, you might go to other things. You might incorporate other activities. It may involve, uh, you know, going for a walk or something like that, or like,
Mm.
other kinds of things that can help your mental health. So, that would probably be the first thing that I try because it's Medicare subsidized as well. So you make the most out of that. So it's increased accessibility at this stage at the moment.
Donald,
So that's what I'll try personally first,
yeah.
in terms of these treatments. Yeah.
That's a really interesting insight as well in terms of the behavior activation component of TMS, that the requirement to go into the hospital or clinic, my apologies, yeah. But there's also every single time, I'm assuming there's going to be a really lovely interaction. Someone with a smile is going to greet you. They're going to say, "Hi, how you going?" The fact that it's happening daily, there's something I think really beautiful and valuable about seeing someone who's happy to see you on a daily basis. You're getting up each day and they're inquiring, "How you going?"
Yep.
There's
Build relationships with these people. Like,
curiosity. There's a
yeah.
relationship that gets built. You might grab a coffee either on the way there or on the way out. You might do a couple of things, some errands, some small things. You're changing your regular, acutely depressed day to now doing something. And obviously, there might be some changes coming out of just that, human connection, some
And that's
kindness.
what we see in the
That's
placebo-controlled
incredible.
studies is that they also show large antidepressant effects just from doing that part, even though they're not getting any brain stimulation. So, but the brain stimulation does add a bit. So that's
Yes,
the
yes. But and this is the great difficulty of running actual research, that the controls are impossible because the conditions are so hard to manage. One person who is getting great effects. We're not quite sure why, but at least we're observing and controlling it as well as possible. But very fascinating, incredibly fascinating. So TMS would be your first go-to for a number of reasons: accessibility in terms of Medicare, cost wise. There is a behavior activation component, the TMS treatment itself, the value that brings. That would be your go-to. And how long is that typically? How is it? Did you say 2 weeks? My apologies, I can't recall.
so usually 4 to 6 weeks,
Four to
but
six.
it's really time intensive. So we're talking 5 days a week for 4 to 6 weeks. So that's that can be a significant barrier for people getting treatment. So if you're working full time,
Sure.
taking the time out to do that, even though there's new approved forms of TMS that only take like 5 minutes to administer, you still have to go drive to the clinic. You still
Yep.
need to talk to people. You may have to wait in the waiting room for your turn to have the TMS. Like it's still, those are still a bit of a burden for
Yeah.
people.
Yeah. Yeah. Maybe note to TMS clinics: make sure there's a nice coffee awaiting to
Well, it's funny in America, like you have a look at some clips on YouTube, and there's clinics that advertise, TMS centers as kind of like wellness centers where you go there, you get your treatment, you can have a massage, you have music therapy, like, It's like you have your cafe, it's like it's all integrated. So yeah, they make it into a real kind of experience. And that's a large part of the antidepressant treatment, I think, as well. Yeah. The antidepressant effects that we see. Yeah.
There genuinely has to be a view of that as well. I know, for example, in my clinic, the importance that I put on the delivery of our service, how someone receives, their first phone call, or how we take that first phone call, how easily we make it, all the information that goes out, how we hold their hand, our attempts of how we greet, how we make them feel like they are, valued and important, and the like. And if the intent is that, I genuinely believe it produces a better therapeutic outcome. I've got no data. I haven't tested it. This isn't controlled. But it just stands to reason that it would be. Like many things, I don't think that psychology is different. And if the people that are greeting you are pleasant, if the people who are greeting you are nice, if the room looks welcoming and warm, but still professional, it can build a very strong expectation, therapeutic expectation of what might occur. If it's a well-oiled machine, they must be competent at what they're doing, and the like. There's an addition placed on the value that they receive, in addition to the talk therapy they actually do receive. That if we kept that as a standard, what are all the other components that we provide? I can see why having some nice music is much more pleasant. I can see why this wellness approach could have value. We don't know, but we're guessing, but it does make some sense. And certainly things like the routine, the behavior activation, the socialization, the social engagement. That's actually positive social engagement rather than that negative. It becomes quite enjoyable to a level. I can understand the challenges of getting to and from. That can be difficult as well. But overall, if the experience is pleasant, wonderful.
And then when it comes to, for people that don't have access to that though, so people that, live remotely, or, they don't have a clinic to go to get TMS, or don't have, accessibility to go to a nice psychology clinic, talk to people in person, have that behavioral activation component, what about them? And so that's where I think the transcranial direct current stimulation, where you can train people to do that, and they can do the treatment at home, and then you can do telehealth. You can have your psychological treatment, you still talk to nice people and have your treatment, but it increases the accessibility for people that don't live in the large cities, don't have those fancy clinics like that often have nice paintings on the wall, or pictures like don't look like a clinical kind of a hospital kind of situation. They sit on a nice chair or a nice couch, where you're getting therapy. But it really opens up in terms of accessibility, is having that tDCS. But then, if you're having that more in the longer term, if you're doing that at home kind of stimulation, and you continue, you could do your psychological therapy with your remotely. The psychological therapy could then help to, once people start feeling a bit better, to give them that, and then the effects of the brain stimulation give them that boost to be able to start doing the behavioral activation.
Yeah.
Things start integrating a routine, doing regular exercise, doing things that, forcing people to do things that they enjoy, to try and help them get better. Yeah.
It speaks to accessibility, the expense, the investment in time, the investment in cost, the investment in change as well. Many people go out and they pay a personal trainer just because of the motivation factor. It's not like they don't know how to, walk or something. But it's a good starting point until maybe they get that momentum, they can do a lot of it themselves. Or if they've got the means, they can continue doing it. But it does speak to the value of it, and sometimes it's really nice having someone who's on your side, who's encouraging, who believes in you, who can watch your progress and say, wow, I'm going to acknowledge that from time to time in our conversations, and they can urge you along. It feels good. How can it not?
Yeah, exactly.
Right. And when you're not going very well, sometimes it's easier to show up for someone else than show up for yourself. So there's so many factors, and it's lovely to hear this, in terms of one's not better than another, but rather these are approaches, there's a battery of approaches, whether it's ECT, which is TMS, tDCS, and understanding that they all have a different time and place, and there isn't a superior or inferior. It's how do we help people overall and whatever works for them, to get them engaged and functional again. So, absolutely lovely, absolutely lovely. And the last one is probably the hardest one is where does psychedelic assisted therapy sit in all of this, and we don't even have that available anyway yet, and there's probably much more research that needs to occur. But I suppose there are some promising signs coming from that intervention as well.
Sure, but it's because of the large psychotherapy component, it's the most expensive out of all of the treatments. So we're talking about, for a course of treatment, 20 to 30,000 Australian dollars. And that's for like one or two actual psychedelic experiences. So I think at the moment it's very restricted to the most wealthy or people who are involved in current clinical trials in Australia. Yeah, it's because there's so much psychotherapy involved, and you need to have, experienced, qualified clinicians to be with the person while they're having the psychedelic experience, which can last up to 8 hours. That's a really prohibitively expensive.
Sure.
And then you need to have the integration sessions afterwards, and then you may have to repeat that all over again, a couple of months later, and then potentially again and again if you're more chronic. So yeah, and then the main issue with that is because it's a combination approach, because it's both the psychotherapy and the effect of the psychedelic experience. How can there's no real appropriate control for that, for doing the randomized controlled trials. So either you're having a psychedelic experience or you're not. And you're pretty much going to be aware if you're in the not basket. So it's that whole expectation, the whole non-specific effects that, we control for with other types of interventional treatments in psychiatry. You can't get that because it's so obvious that you're getting the active treatment, and it'll be so obvious that you're getting the placebo treatment with the psychotherapy. So imagine so you're in a clinical trial, you're getting kind of like the placebo, psilocybin, or a very, very low dose that doesn't, really feel anything. And then you're sitting in a room with the psychotherapist for 8 hours, listening to music with it's kind of like, and nothing's going on. And then you got to come back and talk to these psychotherapists about your pretty much lack of psychedelic experience for 2 days. It's like it's kind of like that's the main issue with that area of research, is that it's like you can't do, so it's very hard, and it's because it's such a integrated therapy. There's so much going on between the biological effects of the psychedelics, the effect of the psychedelic experience, and how your rapport, the psychotherapy component, how it all integrates all together. The complexities in untangling all that are very difficult with our current clinical trial designs. So
I'm an incredible novice in this space, and I think that is actually changing as well in terms of what some of the research is saying. Now, I only can speak from what I've heard and those that I've interviewed, but I think it was Dr. Jerry Rosenbaum from Massachusetts. He ran the Massachusetts General Hospital of Psychiatry Department, I believe it was, who I had on talking about, if I've got this right, my apologies if I haven't, about not requiring the integration or the prep nearly as much anymore. They've got trials that they're running, basically like a pill, with quite promising outcomes, which I was kind of shocked by, because for me it was all psychedelic assisted therapy, and their approach, or at least their research that they've already done quite a lot of, is showing that you can kind of throw that the assisted part. Yes, there's some supervision required and the like, but it's the first that I've heard of it very recently, so I know nothing about it really. But it is interesting, all of these spaces, whether it's the tDCS, which I haven't heard about before, certainly TMS I certainly have with the psychedelic assisted, but there's all these new frontiers coming up, at least being researched, which is lovely, because that's the point. We're trying to use research and a methodology to go out and say what might be available, because there isn't a cure per se, or it's probably in the wrong language, because human beings are going to experience life in a tough way forever. That's never going to be solved. We're just saying, what are the aids, supports that we can provide to people when they're going through particularly difficult times. So, I've learned something, very, very new today as well. So thank you. Where can people find out more if they would like to continue this conversation? Where can they read up more about it? Where can they maybe go to some research? How might they find out more about what might be available in their community? Where to next?
So there's a few kind of resources that I guess are available. So first of all, I think, I've talked about today with ECT, which, is a lot of people have these kind of like ideas about, or negative perceptions about, which may be, mistaken, is the International Society of ECT and Neurostimulation, ISEN. So they have some really informative resources available for people who may be considering, who have that really severe illness, who may be considering ECT. You'll be able to find some resources from them. Also, if you're out at the Black Dog Institute, we have several clinics. So we have a tDCS clinic, we have a TMS clinic, we have a ketamine clinic, and right now we're setting up a psilocybin assisted therapy clinic. So if you go to the Black Dog Institute website and look up our team, and look up these treatments, you should be able to find some resources there as well, and about where these that's a potential source of treatment as well, potential place where you could get therapy. But I guess those are two kind of like starting points at this stage. But if you also for people that are interested, I think you have my bio available. I have a link to my Google has all my publications. I've done research across all these different types of interventions, and you'll be able to look up some scientific papers that may be open access and accessible. And I'd particularly look at some of the reviews that we've written about these different interventional therapies. I think quite a few of them are open access, so people can access the scientific articles for free. So
and what is the website for that, for where people can find
So I
it?
think I provided it in my bio. It's the the Google Scholar. And
Okay,
I have, yep.
we'll
So
make
Google
sure it's
Scholar.
in our show notes for listeners. You can go to the show notes and find it there. We'll make sure it's linked. So you
Yeah.
can.
So just under my name. Yeah.
Lovely. Donald, thank you so much for all of these insights, and thank you for your contributions to date. I know you've got a whole career ahead of you to continue to provide us with the cutting edge information and research and knowledge. I think it all counts so much. And you know, genuinely thank you for your efforts. It's good to know there's new frontier, you know, considerations. And when I say new, I know these things can be decades in the making, but they're still new. And how we go out and find out what is efficacious and not goes through all of these research. So you know, my greatest appreciations for your work and the team as well. It's not only a one-man band. So thank you, and yeah, wish you all the best, and hope we can see these tDCS devices you know, available for accessibility you know, perspective here in Australia and worldwide. It's just important to have as many approaches as we can. So excited to see what the future brings.
Great. Thank you very much for the invitation, and thanks to your listeners for their time and their interest.